Hey, well, nice to meet y'all. My name is Dr. Cooper, and I'm happy to be here taking some time to talk about SPG box and the SphenoCath specifically. As a headache specialist, I tend to take care of people with facial pain, who have migraine, who have post-traumatic headache, and you'll be amazed how many people this affects. To put it in perspective, about a third of the United States population has recurrent headache syndromes. And a lot of them are undertreated. A lot of times they either use a tremendous amount of over-the-counter medicines, things they buy at Costco or things they buy at CVS or Target, or they just kind of deal with misery. Some of them access care to their primary care physician, some access care to neurologists, some go through their dentist for facial pain or for chronic headache. And there's a tremendous unmet need out there. It's been estimated that about half the people who should be getting medical therapy in this country for chronic headache or chronic facial pain just aren't getting that type of care, which is where this device comes into play. Because as you all know, right now, Big Pharma has a lot of tools they use for treating chronic pain and chronic headache. Tablet medicines have gotten a lot of negative rap recently, and for good reason. There can be a fair amount of side effects with tablet medicines. They can be expensive. People have to worry about addiction or dependence if they're using controlled substances. A lot of issues which point towards a different alternative, a newer alternative to help people with chronic headache. And that's what we've seen with our SphenoCath device. So in our practice, we have people who've tried all kinds of things before. And what's refreshing as a provider is to be able to offer a tool that's quick, that's easy, that is painless to do, and for some people can be remarkably effective. So that's what I want to say to get things started at least. I do have kind of a sciencey talk to give, but I'll be brief. I'm just going to focus on the salient points that I think are probably most interesting for you. So the first thing to do, if my slides will start working here, is just to very, very briefly describe how do people experience facial pain, how do people experience chronic headache. And the first thing we know is that there's things that line the surface of the brain. These are what we call the meninges. They're pain-sensitive nerve bundles that go around the blood vessels of the brain. This pain is brought to the body through the trigeminal nerves. These are nerves that bring from the surface of the brain deep into the brain itself. And then the signal goes to various portions of the brain that process pain experiences and can turn on symptoms of migraine like light and sound sensitivity or nausea, or you may know people who have a throbbing headache or whatnot. And our job in treating someone who's got facial pain or chronic headache is to take this overactive trigeminal system and get it to calm down. And there's all kinds of ways of doing this. We're going to focus on the sphenopalatine ganglion, the SPG block, as a way of doing this. So for those who don't like riding roller coasters, if you're waiting in line to ride a roller coaster, your heart rate goes fast, you start sweating, you start getting a bit kind of nervous about it. And that's the normal reflex in our body that can turn on pain for some people. This is called the autonomic nervous system. It's what makes you sweat and it makes your heart rate go fast, but it also turns on or activates pain for some people. And the reason why that's important is because there's ways we can affect that using this SphenoCath device. Some people who get migraine can turn on migraine because of poor sleep, or because they're hungry, or because they've had stress in their life, or they've had a family member who's sick and they're worried about it, or their sleep has been disrupted. And all of those things go through the same exact target that the SphenoCath device targets when you do your therapeutic treatment.
So hey, Dr. Cooper,
yeah, hey.
Can we ask people to mute themselves?
Oh, yeah, thank you very much.
It's very
anyone on the line, would you mind muting out in case you're chewing on a snack or in case you're typing a text about how much you hate this webinar and how sick you are of Zoom meetings to Scott? At least you'll be in quiet then. So yeah, I was just about to mention the sphenopalatine ganglion, and this is complicated, but all you need to know is this nerve bundle that lives behind the nose and the lining of the nose coordinates pain from the nerves in the face, from the nerves on the surface of the brain, back into the brain itself. And it also coordinates our stress response to the lining of our brain, as well as the stress response into our teeth and into the rest of our face. Which means if we can find a way to blunt the activity of that nerve bundle, you can help people. Now this slide just says that people who activate this nerve bundle sometimes have an eyeball that waters, a nose that gets stuffy, sometimes facial fullness, and that looks just like sinus disease or sinusitis, or people have a sinus headache. And it's because they're turning on this nerve bundle. So you guys might even be familiar with this because some people can even have some of these symptoms. And I'm going to show you this tool called the SphenoCath, which can not only reduce someone's pain on the spot in some situations, but it can also turn off a lot of these symptoms people have, like an eyeball that waters or nose that runs as part of their pain experience. So a little bit more about this bundle. It's located deep in the nose, right? So I put a big old arrow on it so you can see what we're talking about. But I'm also going to put a dead body picture on top of this. This is a cadaver specimen. And all that means is we just took a picture of a dead body and put it right on top of that cartoon so you can see just how close this important nerve bundle is to where the nose is. So this is a blunt dissection probe. It goes through the nostril, past this bump of the nose here called the inferior turbinate, past the middle turbinate, and right into the hole on the lateral wall of the nose called the sphenopalatine foramen. You don't even have to remember that because it's not that important. Just know this nerve bundle lives in the lining of the nose really, really far back there. But it's actually pretty easy to get to, right? So to learn a bit more about what the nose looks like, here's the nasal septum that separates the nose. Here's those bumps in the nose called the turbinates. There's a superior, middle, and inferior, but just remember the middle turbinate, because this device, the SphenoCath device, is inserted in the nostril, and it's designed to go above that bump in the nose. So we're not super deep in the nose, we're really just going to the top of the nose. This specialized device has an internal articulating catheter tip, which means when you squeeze this thing together, a small flexible tip bends over that bump in the nose so that when you squirt medicine through this, it's going to fill the back area where that sphenopalatine foramen is. And I'm going to show you what it looks like in just a second, right? So that's all you need to know anatomy of the nose. You need to know there's these bumps in the nose, there's a nerve bundle that lives way far back in the nose, and the SphenoCath is designed to get medicine to that one spot. So one more thing, that little bump I'm talking about, that hole in the back of the nose there, that's the foramen. Foramen just means hole. So this is covered by a 3 millimeter mucous membrane. And all the catheter is designed to do is to go in the nostril, bend over that tip. So when you squirt medicine through this catheter, it's going to follow gravity down to the spot and fill up that hole, which is our target for an SPG block. Again, I just put a dead body picture on top of this cartoon so you can see what I'm talking about. That's the hole we're shooting for. This is the mucous membranes around these bumps in the nose, and that's where we're trying to get to with our catheter. Here's a video of the general concept. So you lay patients flat, their necks pulled backwards and their chins up. You put this catheter in the nostril, you take it all the way to the top of the nose. As soon as you hit the soft tissue underneath the nasal bone, you pull back a ½ centimeter and just squeeze the device together. And when you squeeze the device together, that flexible tip bends over that bump of the nose, and you squirt medicine through the catheter, and it fills up that little bowl-shaped structure where the sphenopalatine ganglion lives. It's that easy. So simple, even neurologists can do it. And for those who have a healthcare background, you'll know that's quite a statement, because us neurology guys tend to be really squeamish about sticking stuff in the nose. Dentists, ER doctors, primary care doctors, no problem. Neurologists get a bit queasy with this. And even in spite of me saying that, this is the most commonly used catheter by headache specialists in the United States. Here's the old-fashioned ways of doing this. The old-fashioned way was used to use a Q-tip, and we dip this Q-tip in numbing medicine, and you'd put it in the back of the nose. Now that sounds easy, except when we used to train our fellows how to do this, we would say you take a 6-inch long Q-tip, put it as far as you possibly can in the nose, and as soon as you feel like you've gone as far as you can possibly can, you adjust it and push it another inch. This is really quite uncomfortable, and you got to leave this thing in the nose, no joke, for 15 minutes to get your benefit. And because your nose has those bony bumps in it called turbinates, this can be painful, and you can get a bloody nose when you use one of these Q-tips. Patients generally don't like it. And on top of that, because those bumps in the nose, these Q-tips can't get to the right spot. They usually miss the target because the nose isn't designed to have a long, rigid thing stuck all the way to the back of it. And since we've adopted the SphenoCath, we haven't used a Q-tip to do an SPG block in the last 6-7 years. The other old-fashioned way of doing this, which is still done in rare situations, is where you take a BA needle underneath the cheekbone. Is anyone who's not muted want to take a guess at what BA stands for? Yeah, it's a word I'm not supposed to say. It's big, and it's a big old needle you're going to stick underneath the cheekbone. And you drive that needle all the way to you literally go from the side of the cheek all the way till you touch the nose bones, and then you dance that needle even deeper in the nose, and then you squirt your medicine in. This requires an X-ray machine. It's really quite painful. And even then, you can get a blood issue where it actually makes the whole face get red, something we call a hematoma. And since we've adopted the SphenoCath in our practice, we haven't done one of these in several years. So let me tell you a bit more about the catheter. Here it is. It's a flexible device. It's got an outside rigid sheath, but it's got a flexible interior purple sheath. You can see it's very flexible, so you can wrap it around your finger, but it's got a product memory to it. So when you relax it, it's going to go right back to its same shape. It's got an embossed arrow on the top, so you can keep that facing upwards. And it's got a lure lock, so any size syringe fits on the back of it. So it's a very, very elegant device, easy to hold, easy to use. Now, what's it for? You know, this is the legal stuff. It's designed to drop medicine onto that specific area in the back of the nose. And it does that very effectively. I'm going to prove that to you in just a minute. The only things you got to worry about, when can you not use it, is if someone has an actively inflamed nose. That means if someone's got, you know, a fungal infection and it's all pus in there, I don't think you want to put the catheter in. If someone's got a nose cancer, this is probably not the device for you, but that's essentially it. And in my practice, we almost never have a contraindication to doing this. If you're looking at it from an ER doctor standpoint, they can apply this, or urgent care, they can do this on almost anyone, and this is going to be faster than even what it takes to start an IV on somebody. If you talk about neurologists, this thing takes 11 seconds. It takes you about 4 minutes to deliver Botox per patient. If you want to talk to people about dentists, dentists can insert this thing, and in 11 seconds, you can do an SPG block, which is faster than it takes them to draw up the medicine before they use a needle to numb someone before a dental procedure. So how do we actually get it ready? Here I've got a syringe with numbing medicine attached to it, and the only thing we do to prepare the device is we roll it in a puddle of viscous lidocaine. Viscous lidocaine is like syrup consistency. It has numbing medicine in it, but it's purely to lubricate it so that when you slide the catheter in, it won't irritate the lining of the nose. Now, it does numb on contact, but I'm going to show you this catheter is only in the nostril for 11 seconds. So it really doesn't do much numbing, because you're really dropping the catheter in the nostril, squirting your medicine, and then removing the catheter, and that's it. So if you're going to remember one thing from today, it's this video. This is the how-to video. So this is our marketing video that we show some people. The catheter is designed to go in the nostril. We train our clinicians to take this all the way to the top of the nose, usually about 4.5 centimeters in depth for most Caucasians. Then you pull it back 0.5 centimeter, collapse the device, and when you collapse the device, that articulating tip goes over the head of the turbinate. Then you drop whatever medicine the clinician wants to use to the back of the nose. And you can squirt, we usually use 1/4 teaspoon of 2% lidocaine in our practice, but I've talked to clinicians who like to use bupivacaine, some people like to use other stuff, and because the device is really just approved to get medicine to that area, it's up to the clinician how they want to apply it, how they want to use it, where they want to use it, what patients they want to use it in. So this is me doing it on an actual patient of ours. I'm going to show us a couple times, but don't blink. It's 11 seconds long. So she's laying flat, her neck's extended. The catheter goes in her nostril. I go all the way to the top of the nose. I collapse my device. I squirt 1.5 cc's, and I pull it out. And you'll notice on this video, she's not trying to karate chop me. She's not wincing in pain. She's just chilling, right? Because it feels like someone's picking your nose for about 10 seconds. There's a pinch at the end. The medicine we use tastes bad, but the actual catheter itself is not very painful to insert. Let me show you that one more time, because it's a fast video. A couple key things. She's laying flat on her back. Her neck is extended, which means her chin's tilted upwards. You're going to see me insert the catheter. I've already got it lubricated with that numbing gel on it. I'm going to insert it in her nostril, and I'm going to take it all the way to the top of her nose until I can't take it any further. In her case, it's about 5 centimeters. I then collapse in the internal catheter, I drop my numbing medicine, and I slide it out. That's it. That's the whole procedure. No needles, nothing sharp. This is a quick, easy thing to do, and also very well tolerated. Now, Heather, who's our video model for this, she's actually a patient of mine, but she's also a physician. She's tried all kinds of things, and this is by far her best treatment to date that she's had for treating her chronic headache syndrome. Let me show that one more time, because I'm trying to impress on you just how quick, just how easy this is, and then I'm going to show you how we know it's effective. So this is the quick, easy part of it. Lay in flat, neck extended, catheter goes in the nostril. I haven't sprayed her nose with anything. I'm just putting a cath with numbing gel into her nostril. Goes to the top of her nose. We squeeze the device together. I squirt in my medicine, and I slide it out. That's it. Very, very simple. So this is that picture I showed you before. Some people get eyeball watering, nasal stuffiness as part of their facial pain. This is also a patient of mine, and I want to show you this picture because when I clicked this, she came to our clinic with 2 months of persistent right-sided headache, and her pain's bad, her eyeballs watering, her eyelids drooping, which are things we sometimes see in our practice. 2 months of persistent headache, and she'd been to the ER 3 times before I clicked this picture. We did a SphenoCath just like the video I showed you. Here she is, no joke, 10 minutes afterwards, right? What I want to show you here is not only is her facial droop a bit better, not only is her eyelid droop a bit better, but she's smiling. And it's not because I told a funny joke. Any of our residents and fellows will tell you I'm just not a funny guy, even though I try really, really hard. But she's smiling because her pain is down from what she verbalizes an 8 out of 10 for 2 months straight. 10 minutes after putting 2% lidocaine in her nostril using the SphenoCath, now she's down to a 2 out of 10 pain. Right? High fives for everybody. If you bring this to the urgent care, if you bring this to neurologists, if you bring this to primary care doctors, if you bring this to dental professionals, they can have that same experience. High fives for everybody because you've done something quick, something without a needle, something without tablets that turns off someone's headache relatively quickly, not for everybody, but for a lot of people. And it's easy to do. And it also reimburses nicely for their practice. This is just research proving it works. So the first one, and I'll be super quick because I know everyone's time is precious here. So this one is just the 2003 research study. This was published a while ago, but I show it because it was so impressive to the American Headache Society that it won the Wolf Award. The Wolf Award is given out once a year for the most impressive research in the headache field. And this showed essentially that if you do one of these treatments of lidocaine to the back of the nose, you can turn off acute migraine. So an impressive study. I can email this to anyone interested. It just proves that it works way back in 2003 before they had these specialized devices. So they had to make their own kind of handcrafted device for this. So that's the first article. This not only did they show that people's pain got better, but they also showed that their temperature of their cheek got improved. And I'll show you why that's important in a second, more to validate what we're doing in our practice. Now, this article just got published in December of 2019. All they did is they polled the American Headache Society members in the United States. So I'm a card-carrying member, happy to say that. I have been for a long time. I got this survey, as did most of my brethren in the headache space. And all they said was, do you do SPG blocks in your practice? If you do SPG blocks, do you use a catheter? If so, which catheter do you use? And what's your outcomes been? And so we found with this research study published, and this was not a sponsored trial by any company, this was done organically by the American Headache Society, but they found the SphenoCath was the most commonly used catheter. They found that chronic migraine was the most commonly used disorder for the catheter, and the people who responded best were chronic migraine. But that's not to say that people with trigeminal pain, which is facial pain, people with dental pain, those kinds of things, those people could still get improvement from that. It's just that they were not the most commonly treated in this study. What's exciting about this is this was published in a very important journal. This was published in the American Academy of Neurology's Clinical Practice Journal, which is a journal that's accessed by thousands of practitioners around the country. And again, not sponsored by Doler Technologies, not sponsored by anyone else. It was just showing that this catheter certainly is well respected in the headache space. So I'm almost done here. I just want to show a few more things. The first thing is we know these catheters work because they can turn off autonomic symptoms. And I just want to prove that with this article. This was published by myself and some colleagues at the University of Michigan. Not only did we show that people's pain got better when they got an SPG block using the SphenoCath, but they also showed a change of their cheek temperature. Now, I know you're thinking that's not an important finding. Who really cares about that? That's what I would think too, except this proves that not only do you reduce pain, you also affect the inflammatory response and you affect the, what we call the autonomic response. That thing I was yammering on about stress and sleep and whatever at the beginning of this presentation can be improved by doing this procedure. Hey, for those listening in, could you please mute your lines just so we don't hear you talking on the phone? Thank you very much. So how about side effects? Who gets side effects from this? We almost never see side effects, except everybody gets a bad taste in the back of their throat. That's because if you're using a numbing medicine, it's bitter. More articles, these are both real quick. This was published a while ago in 2018. This was using the SphenoCath, and it showed in the ER setting, people who show up with acute migraine who got an SPG block, 71% were free of headache in 15 minutes, 78% were free of headache at 2 hours. These are people coming to the ER, and you can see their reported pain scales drop from an average of 7 down to an average below 1 quickly using this device. This was published in 2018. One other study I want to show you, this was an SPG block. This was the same study, same people. So in the ER, people coming in with acute migraine, overall, patients felt very good about their experience or good about their experience. Only one person at 2 hours said they were unchanged by this. So forgetting whether or not it was pain-free or not, people just generally like this device. Now, one last study to show you is this. People generally like the SphenoCath because it's quick and easy. Now, this one was done for acute migraine headache, but the other one I want to show you is this one. This one was for facial pain. So this was where people showed up in the ER with what they determined to be facial pain. Now, most of this was dental pain, and they did an SPG block using a different technique with a Q-tip, and they also just used standard of care, which was medication treatment. And you can see people who got the SPG block did better than the medication effect for facial pain or for dental pain, mostly in this situation, than even getting your typical medications within the ER. And again, about likeness, we know that people's pain reporting can be variable. They use something called the McGill Pain Questionnaire, which is a validated survey of not only pain, but also functionality and also associated features. And people did well with doing SPG blocks and facial pain on that scale too. So again, patients like this. It's quick, it's easy. There's no tablets. There's no controlled substances that I recommend using through this device. And pretty much anybody can do it. This was the summary from that article. Again, this was for facial pain, but they summarized exactly what I was just trying to tell you. Published in their article from 2018, they said a transnasal SPG block is easy to perform, effective for reducing source of intensity of pain, not age-related, is safe, and a low-cost treatment for multiple facial pains. This is, of course, a Roman article, so excuse their English and lack of translation there. But overall, effective in facial pain, effective in headache. So just to summarize, a few review terms, just so you know what you're getting into for a second here. We know that the sphenopalatine ganglion coordinates pain to the lining of the brain, coordinates pain to your teeth, coordinates pain to your temporal mandibular joints, coordinates a lot of pain in the body, but it also coordinates your autonomic response, which means your stress response to the lining of the brain, your emotional response, your change in sleep, all the things that we think can bring out headache can be affected by this nerve bundle. We know the middle turbinate's our target. If you have a device that can go above that middle turbinate, you can squirt medicine right on that bundle of nerves in the back of the nose called the sphenopalatine ganglion. This can reduce irritability of your autonomics. It can reduce your body's activation of pain to the lining of the brain. It can help you reduce pain, but also autonomic dysfunction. And all this is because of the SphenoCath, a device that provides quick, needle-free, painless, and an easy sphenopalatine ganglion block for any providers out there. So that's what I wanted to share. Any questions out there? I'm sure Scott's got a bunch.
Yes, There are several. Let's see. Let's just take a look here. Let's see. What are the indications for the SphenoCath? We have a PI to share with those clinical providers. So okay. But what are the indications? What are you looking for when a customer or a patient? I'm sorry, a patient comes in.
Sure, I get it, Scott. So so here's the thing. The FDA has approved this device for delivering medication to the sphenopalatine ganglion area. So there is no specific indication for limitations to any specific disease state for this. It's up to the provider to choose how they want to apply it. So from my perspective, it can be used for any of the headache syndromes out there. We use it in our practice for chronic migraine. We use it for post-traumatic headache. We use it for trigeminal neuralgia. We use it for temporomandibular dysfunction. And we also use it for people who've got dental pain. So one of the things we would see commonly in our practice is someone who has had a dental extraction and now they got facial pain that's been there for months. They come to our practice. In that case, you can either use a bunch of tablets that have some systemic body side effects, or you can try one of these devices. And this actually gives you benefit sometimes within minutes, sometimes within a couple days. But it many times is a much cleaner, faster, more efficient way of treating that. I've had other people use, I know other practitioners who work in the urgent care setting, and this has become a tool to treat people's headaches so they don't have to start an IV sometimes. I know some people use this in the primary care setting as a way of treating any headache that comes in. Our institution, as an example, is going to be just launching a research trial for post-concussion headache syndrome. So you can imagine if you had, a sports injury, let's say COVID ends and people are playing sports outside again, and someone smacks their head and they're 17 years old, I would much rather my 17-year-old get squirted with lidocaine through one of these devices than put them on 3 months of a tablet medicine like Depakote or Topamax, or to put them on pain medicine or whatever else. And if it doesn't work, you haven't lost anything. You've squirted, what we use is lidocaine. So you've squirted a medicine that's out of the body in less than 24 hours with almost no side effects to the body. And one other area that seemed to have kind of taken off for us is in the OB world. So if you can imagine pregnant women who've got headache of any kind, they go to see their OB. The OB doesn't want to use any prescription medicines because you got to worry about the fetus as well as the mother in that situation. This is a very clean way of treating headache in that situation also, because the medicine that we use is gone and safe in pregnancy, gone in 24 hours and safe in pregnancy. And again, there's no needle with this. You're not using a pokey, jabby needle or anything. You're really sliding a rubber catheter in the nostril and depositing medicine back there.
Great. So you mentioned what the solution was you use. You use was it 1 or 2% lidocaine or something like that?
Yeah, great question, Scott. I typically use 2% lidocaine without epinephrine, but my partner who works in the same office, 2 doors down, he likes to use 4% lidocaine. My way's better. Just ask me, I'll tell you all about it. But I've had other practitioners who've used bupivacaine, which is a numbing agent in that same category. I know some people have had interest in using other medicines besides the numbing agents. For instance, there's a practice that's in California that commonly puts an anti-inflammatory medicine in through this device. There's another group of clinicians around the country that like to use what they call stem cell therapy through this. So you can apply it for a bunch of things, but by far and away, the most commonly used medicine in here is going to be 2% lidocaine without epinephrine.
Great. Have I seen a video where you do both nostrils at one sitting? Is that correct?
So yeah, so there's a bunch of videos circulating out there with this device being used. I commonly do both nostrils at the same time. I just, for brevity, I was told by Nick, I've got a brief period of time. Don't waste these guys' time. They're very important. And I wanted to make sure I got to what I need to get to. But yeah, I would, and the patient I showed you, my patient where I'm doing the device, I would do that one nostril, then I would re-lube the device and that numbing gel again, the viscous lidocaine, and I'd just go jump to the other side and do the other side. I'd use the same device for that one patient experience, but these are single-use devices. So as soon as you've done both nostrils, you discard it and get ready for your next patient. You don't reuse this on the same patient 4 weeks later or whatever else. This is a one-time use catheter, and that's clearly an issue. You would never want to have a patient, take this home or have the clinician keep it, because who knows what's going to grow on that thing, and then you're liable for it.
Right. Speak, if you will, for a moment about who can actually administer this. What what licenses, what certifications they need to have?
Yeah, great question. So I don't know how to best answer that because usually nerve blocks are done by some type of providers. I know that chiropractors can do this. I know dentists can do this. I know any physician can do this. Well, you know, I like to pick on my colleagues who are radiologists because they can hardly do anything, but I guess they could too if they wanted to. But yeah, so any provider out there can do it. Chiropractors can do it. Dentists can do it. And then when you start going into the other integrative medicine providers, if you're doing it for cash, I don't know if you can do other providers out there, but that is a huge breadth of population to cover. As an example, this company, Dollar Technologies, we're providing a similar presentation to this at the American Academy of Orofacial Pain. Now that environment is almost all dentists, and I fully expect them to have a huge interest. They have before, obviously, but we're kind of hot on their radar because this device fits perfectly to what they do. American Academy of Orofacial Pain are a group that do facial pain, obviously, but also TMD work. And this is a perfect device because it's quick and easy. So I hope that answers your question.
Okay. Yeah, it does. And I think, is it considered an injection, even though it's not penetrating any tissue?
That's a great question. And your question is pointed only because the American Medical Association reviewed their coding for these types, for this device specifically. You got to be famous if you're actually named specifically by the American Medical Association when they review a device. And the reason why is because radiologists for 2 decades have been making the claim that a catheter is providing an injection if you're using a syringe and pressing medicine in the body, even if there's no needle. So this is technically an injection of medicine, but there's no needle with this. So if a language for a description of a procedure includes needle, then you're not allowed to use it for this device. But if it's an injection, you're allowed to use this.
Okay, perfect. Let's go back to our questions here. Let's see. You said one question was, you said right side pain. Does it matter which nostril you apply it to? We've spoken to that. You do both nostrils.
Yeah, let me clarify that real quick. If someone has exclusively one-sided headache, then I will sometimes do one side. But most of our patients, even if they come in and say they have one-sided pain, they generally mean they got one side that's more intense than the other. Now, the times I will do one-sided will be mostly for my trigeminal neuralgia population, or for my people and that's that sharp, stabby, shock-like pain in the cheek. And I'll also do one-sided for my dental extraction or persistent tooth pain people. They'll be one-sided for that.
Okay, great, thank you. Let's see, you mentioned urgent care neurologists, dentists, pain specialists, PCPs. Is there anyone else that we should be targeting?
Yeah, I think the OB market responds really well to this too. Know that OBs treat women aged 20 to 45 by definition, and they're the most likely to have recurrent headache syndromes. And a lot of women in that age group get their headache care from their OB. So this, and OBs don't like prescribing medicines in general, as well as they like doing things with their hands. So this becomes a pretty easy thing for them to do. Or at least to be aware of, and they can refer to someone if they don't want to do it themselves, someone in that community, so you can help set up these referral paths to clinicians. The low-hanging fruit, of course, are going to be people who do a lot of headache work, which is going to be pain clinics, it's going to be neurologists, and then urgent care ERs. But those other groups are also good targets, I would expect, and of course our dental population.
You mentioned some immediate relief sometimes in many cases. So before they even leave your office, their pain levels have gone down. Is there some indications that would say maybe a person wouldn't receive that immediately? And if they do receive it, how long are we expecting? Is it 2 months, 4 months, 6 months? What do you think?
Yeah, great question. And so the frustrating but honest answer is it's quite variable. So I showed you in the ER article published in 2018. I know I whizzed through it, and I'll email those to anybody who's interested. But they showed acute pain response in 15 minutes in 70% of the people who came through, which is better than their typical medication response, by the way. So, and that's really impressive for an ER type setup like that. Our experience in a chronic headache clinic is a bit different. The people I take care of aren't ones who are doing well and then have a headache they can't stop and then are doing well for 2 or 3 weeks again. The people I take care of have some degree of headache most of the time. And in that situation, they're more of the delayed responders. But if someone rolls into the ER, I think there's at least a 2/3 chance they'll get a great response immediately, better than what we get with IV medicines, by the way, and usually within 15 to 20 minutes. Now, what you would tell one of the providers, let's say you're talking to an urgent care provider or you're talking to a neurologist who does treatments in their office, you would say if they don't respond, you can do whatever you would normally do. There's no reason why you can't combine this with your other therapies. But if I'm running a busy urgent care or running a busy ER, I want the patient seen in the clinic as fast as possible. I want them out of the clinic as fast as possible, so my turnaround's as quick as possible for efficiency. Remember, they're paid by visit, not by how long someone hangs out there. So if you can offer them speed of treatment and quick response, and again, this would take away any medication effect from them, it's a slam dunk in my opinion.
Okay. Just a couple of more and then we'll let you go, Dr.
Sure.
Cooper. Thank you. Would you address how long the maybe pain relief lasts?
Oh, thanks. Yeah, you asked about that too. So that also is variable. What I typically see for our good responders, it's 2 or 3 months or sometimes much longer than that. Sometimes your acute headache response lasts just a week or two, and then they're vulnerable for the next breakthrough headache if you're using it in the ER setting or whatever else. But generally, it's several weeks in duration. Now, nothing works for everybody. So even if you look at our best IV medicines, our best tablet or our best injection medicines, none of those are 100% for anything. So getting these types of numbers is pretty impressive.
Thank you.
And let me, one last way of answering that. So if I do it in my clinic for someone who's got chronic headache for a long time, and I'm using it more as a preventive tool, which is what we do in our practice more often, our expectation is the first time they'll get at least 4 weeks of benefit, and then the next time they'll get at least 2 months of benefit, and our target is more than 3 months at a time. We don't always achieve that, and some of my patients are satisfied with 4 to 6 weeks of relief each time, and so we'll do them every 4 to 6 weeks, but I expect and I hope to see it for a benefit of more than 3 months.
Yeah, a couple of questions here about the duration. Okay, you've mentioned chronic facial pain, that it does help with that, the trigeminal neuralgia. Okay, just going down here. Is SphenoCath a patented technology? Any other competitors using a similar technology?
Yeah, great question. So, and some of this I'd have to defer back to the company, but I'll answer what I know. The catheter is certainly patented. This was the first SPG block device patented in this country. There was a competitor that was a knockoff device, and they have since left the market. So they're no longer around as far as I understand it. And then there's also a competitor device that works in a different way. Theirs isn't as elegant as ours. Their device goes underneath the inferior turbinate, and instead of dropping aqueous medicine that fills the area that I pointed out on our picture, theirs puffs up a numbing spray to it. And because of that, their duration of benefit is less, and their ability to turn off a more severe headache is less, in my opinion. We carried both at our institution for a while, but our whole group shifted over to this because of efficacy. So from a competitor marketplace, that's what you should know about. And as I mentioned, I think it's important to remember that article from the American Academy of Neurology that was just published back in December of 19 showed that this was the most preferred device out there.
Perfect. Yeah, we'd love to have all those articles, and I may already have some of them. I have a plethora of them, but we'd love to see yours as well. So,
okay.
Last couple of things. There was a very specific question about regarding a lidocaine and marcaine mix. Any input there?
Yeah, I think I even know where that might be coming from. So when we do other types of nerve blocks in the clinic, these would be the more traditional, using a needle, injecting under the skin to numb a nerve in the back of the head or in the eyebrow like we do on a regular basis. Some people will combine both lidocaine and marcaine, known as bupivacaine, because they have different durations of action. And the concept is if you have numbing medicine that lasts just 2 hours combined with numbing medicine that lasts 12 hours but starts slower, you get a more robust response. That is 100% up to the clinician and absolutely can be done with this device. I've seen it done with this device, and that's up to the practitioner's discretion. So if you're calling on a provider and they prefer to use that combination, all you say is, hey, that sounds great. I've heard of other people doing that. You know, of course, because this device is not approved for a specific medicine, it's 100% up to the provider what they want to put through that. And I would have zero concern safety-wise of that combination. In my personal opinion, I think the lidocaine works really well by itself, and nobody's done a head-to-head comparison of efficacy between the two, except for one poster presentation which showed the lidocaine was slightly more efficacious, but it was only a small study.
Okay. Great answer. Thank you very much. Last question. Can you speak to us about what you use in your clinic, cash pay versus insurance based, and how that might work with this product?
Yeah, great question. So I'm at the University of Michigan, and we exclusively take insurance only. There's no cash pay program unless someone's going to just pay regular as if they had no insurance. So we can't adjust pricing. And because this is a procedure, and I work in a health system that has a large facility fee, I don't have a way to waive that. So where I'm at, it's all through insurance. And it does sometimes take an authorization before you can do the procedure. But as my business manager will tell you, this procedure makes more for our clinic in 11 seconds. Truthfully, it's a 50-minute patient visit for us than me spending 1 hour talking to somebody. So for them to get the authorization, it is certainly worth their financial time for. Now, some of my colleagues and friends work in private practice, and in that situation, they can choose when they want to accept cash pay and when they want to go through insurance for it. So some of them do cash pay for this. And for them, it's been quite lucrative, and the word is kind of spread. So they get a lot of patients coming to them, and especially if an insurance either won't cover it for a specific issue, then you can go to cash pay. And then there are some practitioners who just don't take any insurance at all, who are just cash pay models. And a lot of dentists are in this situation, a lot of integrative medicine physicians, a lot of fee-for-service or concierge physicians are in this situation. And then it's straight up cash pay. And in that situation, you can negotiate your own rate for that. And I've seen the rate for this procedure all over the board. So if you go to, ritzy places in California, people are charging, north of $600 per treatment for this. If you go to more financially strapped regions of the country, that number is usually around 200 or so for this device, for this treatment for the practitioner.
Great information. Thank you, Dr. Cooper. A wealth of information. Hopefully we'll have an opportunity to hear from you again in the future. We really appreciate this, and we're going to roll this out and hopefully help some of your colleagues alleviate pain across the nation.
That'd be fantastic. Thank you, everybody, for your time.
Thank you.